Zimbabwe has extended its level 4 national COVID-19 lockdown by 2 weeks. The acting president and Minister of Health and Child Care, Dr. Constantino Chiwenga, said the extension has been necessitated by the need to save lives. Zimbabwe has reported 32,646 coronavirus cases so far and 1,160 deaths due to COVID-19, along with 24,419 recoveries from the disease. Vice President Chiwenga also said there is a likelihood of new strains and variants circulating which are more transmissible and infectious. The current lockdown came after 4 government ministers died of the coronavirus. My colleague Peter Ndoro spoke to the country's chief coordinator of the national response to the COVID-19 pandemic in the office of the President and Cabinet, Dr. Agnes Mahomva.
We've seen quite a surge in COVID-19 infections and deaths, sadly, in Zimbabwe of late. What do you attribute this to? Is it perhaps a new strain that's come to the country?
It's very possible. I think we are learning from South Africa, where you are, that there is a new variant and so on. Quite clearly, as long as we have the kind of borders that we have, it's bound to come our way as well. But of course, we still have to confirm it. So that's point number one. But I think the most important and critical one really is the complacency that we've seen in our communities. You are aware when we had the first wave, we really ran around Zimbabwe, like a number of countries in the Africa region. We were able to institute those public health and social measures, including lockdowns, very early on. And people were really complying. We were like, oh my God, what is this virus now? And we complied. But of course, as we managed it reasonably well, it settled. People were thinking, oh no, there's nothing to it. This is just like a flu. And so we started struggling to get our people to appreciate that actually we need to still mask up and do all those things, washing our hands and so on and so on. There was just such complacency. And we really feel very strongly, I might add, that that is perhaps one of the biggest contributors to this second wave that we're in.
And we've just seen yesterday that you have extended your national lockdown to February the 15th. Is this an indication that the first portion of this lockdown just wasn't doing the trick?
Oh, on the contrary, this first bit of the lockdown was doing exactly what it was supposed to do. We're beginning to see the results. If you're looking at our epi curve, for example, the numbers are actually have settled and they're actually on the downward trend now. So we just need to tighten up and hold on and make sure that we are really continuously on the right path. So absolutely the first lockdown, i.e. the first of this second lockdown, the first part of this second lockdown has done exactly what it was supposed to do. This extension simply means let's make sure it really takes us all the way to where we want to go.
Do you have a clear picture of the extent of the problem in Zimbabwe? I think one of the challenges for many countries across the continent has been resources and testing as fully as a country would like. What's the situation in Zimbabwe in terms of testing and trying to map the virus across the country?
So glad you asked that question. From day one, we struggled with our testing. And we actually, when we compare notes with countries in the region and across the oceans, for example, it's very clear that this has been the biggest challenge for most countries. Zimbabwe is no exception. So no, we're not testing as much as we really would like to, but that has not stopped us from doing exactly what we need to do. We have remained focused, made sure we're doing everything that we need to do. But to be able to say what exactly is the situation in our communities, we've gone on to do a prevalence survey. A nationally representative sample was taken, and I'm very happy to say we finally managed to carry it out towards the end of last year. And as we're speaking, our scientists are just finalizing analysis of that data. That is going to tell us exactly where we are, and that will inform how we strengthen, revise our plans and our actions, as well as our main strategies.
Are you testing asymptomatic people? Because they are in the majority and yet they are actual spreaders as well. So will that form part of this study?
Well, the prevalence survey does, of course, look at various people in the community. It's not, you're not trying to identify those who are sick, if that's what you're asking, but we really need to see the representativeness of who is positive out there, whether you have the symptoms or not. And it's scientifically based protocol that was put in place, approved by our Medical Research Council. We had lots of support technically from the CDC, Atlanta, from Africa CDC, and many others. So we're very confident once we actually get these results, which should be coming out any minute, if not this week, we are able to replan. So yes, it was looking at the whole population and not just those who are sick or who have symptoms and so on.
All right. What about genome mapping? Are you doing any of that so that you can see if you have variants, or you're just doing the job that you can to stop the virus in whatever form that it's coming in?
So we can see if we have the variant from South Africa and other places. We actually, our scientists, lab scientists, did do some genotyping for the first wave. And at that time, we didn't have those variants that are now coming up. We since tasked them to look at the genotyping of the second wave, and they're working on that one. Of course, we've had challenges here and there, but we're really working on it to make sure that we actually are very clear. In addition to the prevalence survey that I talked about, in terms of what is the prevalence like out in the community, we also want to know the variants that we have. It really does also help us step up our response, put in place the measures that are required based on the nitty-gritties of what science then tells us.
Has the coronavirus reached the rural areas in numbers? I know Zimbabwe is predominantly rural. The urban areas are highly dense, and you see a lot of travel there. And so one would expect the virus to be prevalent there. What's the situation in the rural areas?
It has. When we started, it was really imported virus, and so we didn't have it in the community. But as we're speaking now, this is really transmission mostly happening in the communities, and our communities are spread all the way from the urban to the rural, and so it is there. When we analyze our data, we're looking at the data not just from Harare, Bulawayo metropolitan provinces, we're looking at all provinces, and most of our provinces are rural. And so this second wave has very clearly demonstrated that this virus is all over the country.
So let's talk a little bit then about what people can do, particularly in the rural areas, because access to water, soap and things like that are much harder out there. How are you helping Zimbabweans who perhaps just don't have some of the things that people take for granted in the urban areas to combat and do the daily hygiene that you recommend?
A lot, actually. If you remember when the pandemic started, His Excellency, the President, Comrade E.D. Mnangagwa, put in place an interministerial task force that really helps coordinate and guide the implementation of our preparedness and response plan. And in that, there are 8 subcommittees that look at the various aspects of this response. And one of those subcommittees specifically looks at the welfare of the population, in view of the fact that we're very aware that a lot of the majority of our the largest percentage rather of our population is out there in the rural areas. They are affected very differently from those in the urban areas. And so that task force, the subcommittee that looks at the welfare of the population is actually seized with that aspect, looking at whether it's grain distribution, whether it's cash payment for those who have just not been, or rather who have found themselves without any employment and so on because of the COVID situation. So that's what we're doing. And of course, we're strengthening how that subcommittee works to ensure that it doesn't just focus on the urban areas, it also focuses on the rural areas.
Let's talk a little bit more about resources and the equipment and facilities that you have at your disposal. Is Zimbabwe able to cope with the numbers? And if these numbers do a 3rd, 4th surge before the vaccines start to take effect, Do you have enough capacity to manage the disease? I think, it's fair to say that hospital facilities in Zimbabwe have not had huge investment over the years.
That point is very true. And in fact, we start from there, recognizing that our facilities have not had a lot of inputs and so on, and hence are challenged. We then map out and say, what is it that we can do? Just to come back to your question where you're saying, do we have the capacity? I think it's good to remind ourselves that we haven't seen any country that has the capacity, the real capacity to manage this virus. So Zimbabwe is no exception at all. What we have done is look at that and say, okay, so what is it with the capacity that we have? What is it that we need to do to make sure that capacity manages our cases well? And in that spirit, we've pushed so hard to make sure that the message goes out there in the communities that it's over 85% of the cases do not need to be admitted to hospital, and therefore it's best that they are managed at home. And of course, we give the guidance and guidelines to do that. We have gone so much more in terms of strengthening our communication to the population to say prevention is the best way to go, because if we prevent it, then we're actually making sure that the small capacity that we have in our facilities and so on can manage the few cases that are there. So that's our approach in Zimbabwe, realizing that our capacity can never be enough, the facilities, the equipment, you name it. But we can't sit around crying and thinking we just want more ventilators, more this. Let's make sure the numbers that eventually get to the hospital are so small that the capacity that is available can then be able to manage it.
You've had challenges with your frontline staff, your healthcare workers, over issues like pay. They've complained also about protective equipment. Has that been resolved to a point that people are getting the care that they need, and that there aren't any healthcare workers perhaps not showing up to work for fear that they might die because they don't have enough equipment?
Well, that fear will always be there. We're doing our best to really assure our healthcare workers. We're doing as best as we can to get more PPE. And the government of Zimbabwe, right from the beginning, actually decided that we want to ramp up local production so that we are also producing some of this PPE. If you remember way back, we never talked of disposable gowns and so on for theater. And so on. So we have decided our companies here can manufacture lots of that so that we have enough to cover our healthcare workers. So we continue ramping up local production from the private sector, from our universities for PPE. But of course, it's never really enough. PPE is like a loaf of bread. You have it today, you eat tomorrow, you want another one and so on. So it can never be enough. I know many have said, oh, you got donations from JECMA, you have donations from here. It can never be enough, and hence the ramping up of local production. In addition to that, we're also training our healthcare workers to make sure that once again, the limited resource is used appropriately. When we started, we had so many healthcare workers wanting to wear the Tyvek suits just to stand at the gate and take a temperature, when in fact you could do with less and let that whole suit be used by those who are in theater and so on. So we've got clear guidelines in terms of who uses what PPE at what level, in what space, and so on, for that maximum protection for everyone.
Do you have any idea how many healthcare workers have been infected and sadly have died as well?
We do have those numbers, Mr. Ndoro, but we are actually still analyzing, because it is very clear that in terms of us gathering that information, compiling it together and so on, it's not quite there, but we do have a number that we have, and we're still chasing it up to make sure that it is comprehensive, because as you are aware, government took it upon itself that for those who get infected at work, for example, they really must also be compensated. And hence, the drive to make sure that whatever numbers we give out there are accurate. We don't then want to give numbers that are not so accurate, and then we run into problems with our healthcare workers. But this is no secret. Government has decided they want to really make sure that those who are infected at work and so on get some compensation, if you like, and then we are able to still ramp up and make sure that the PPEs are in place, the appropriate utilization of PPE is understood, and that it is distributed appropriately. So we're working very hard on that one to strengthen our response and indeed to really support our healthcare workers. We cannot do anything without them, and we are so grateful to them. We are really appreciative. But of course, as I've said at the beginning, our challenges are still there. We can never run away from them, and we'll always say it. We don't hesitate.
We've seen, sadly, as many as 4 cabinet-level ministers passing away from this disease. Are you concerned that the protocols are not being followed at that level of government? And, you know, a lot of people probably translate that and saying, if our ministers are not safe, I mean, what about us?
I do think human beings are human beings, Peter. You know, the complacence we're talking about cuts across everybody, the whole board, really. And so I wouldn't want to single out our ministers and so on and so, oh, they are not doing XX. It's really us together as a population working together to appreciate that risk that is there to individuals. The individual could be a minister, it could be a gardener, it could be anybody. We are all human beings. And so the perceptions that we have are very similar. So it is just left to us as a task force, as those who are working flat out to strengthen the response, to look at those challenges, to identify them, and then strengthen how we respond to them. And indeed, we are really ramping up in terms of how we implement our protocols to protect our task force and everybody else at that highest level. But remember, I said at the very beginning, to protect everybody, including the rural areas, anybody and everybody in Zimbabwe.
There's a feeling that the higher up you go in the system, the rules don't apply. We've seen images of parties and so on and so forth, which are super spreader events. Is a message from the president getting through to people at senior level that they've got to set an example? Because, you know, people will say, we're not going to behave if our senior leaders are busy having parties and super spreader events.
Well, again, as I said earlier, that human beings are human beings. It's not just about ministers, about the poor people out in the rural areas. It's us all. And remember, this is not something we're saying, do this for government. Do it for yourself. And so that message going out there is for both the highest level, the ministers, the lowest level, you name it, because it's for individuals' health. That then, of course, translates into the health of the nation together, if you like. And so it is true what you said, the higher you go, people look up to you and so on. I think the ministers and everybody is really, they're working very hard to make sure that that message is clear and to avoid those super spreaders. Yes, there might have been 1 or 2 here and there. Again, that's really more human nature than anything else. But I think when we're looking at the second wave that we're really riding now, I think that message is hitting home at every level, the highest level, the lowest level. And we sincerely hope as we move forward, it is actually translating into good understanding and hence help us to strengthen our response.
We've seen a few high-profile people being put into custody recently, and they've talked about the state of prisons in Zimbabwe and how COVID-19 perhaps is easily being spread in there. What are you doing to protect people that are in prison and also people that are waiting trial, perhaps who are there for a few days and come out with COVID-19?
Well, it's good you're asking that question. It really emphasizes the focus of our response. We are saying every Zimbabwean deserves the best. Whether you're in prison, whether you are in the rural areas, whether you're in the urban areas, whether you are in the minister or whatever, it's about prevention. So to come to your question, what is it that we're doing? It's the same message: prevention, prevention, prevention. We simply say the facilities that we have are not really adequate to admit everybody, and hence we need to focus on that prevention, which really means the social distancing. I think the prisons have been looking at that to say, how best can they do that? Do we need to make sure that those who have who've committed smaller crimes are put in their own? All those things, they're actually looking at it and saying, what is it that we need to do? Remember, even before COVID, we had challenges with our prisons. We had challenges with our health facilities. We had challenges with our schools because of the economy. Zimbabwe's economy is no secret to everybody. Of course, it is on the path to recovery. Unfortunately, COVID came in when we were just climbing up, and it's sort of pulling us back down. So it simply means, once again, we need to say, this is the resource we have. Let's not dream and think it's going to suddenly be fantastic. What is it that we can do? Prioritize and make sure that that limited resource can cater for those who go into it, prisons included.
And I'm talking about prisons because we know that they are overcrowded. They have, again, investment in prison facilities hasn't been huge. And I just get a sense that in a crowded place and access to resources for prisoners limited, you could be seeing a lot of people dying in the prisons unless urgent action is taken.
That is very correct in sense of saying where you have crowds, this is where this virus really thrives and likes. And this is why we always say avoid crowds and so on and so on. So as I said earlier, this is an area we're actually focusing on. I do like when you say people could die. And once again, we are looking and analyzing at our data, because remember, we have always said as Zimbabwe in our response is guided by science. And that science is not about high-powered research from global or anything. It simply includes proper analysis of our data, whether it's coming from the prisons, so that we are then able to focus and say, we're doing so well, so maybe we're already doing things correctly. Oh my goodness, we're doing so poorly here. Look at the numbers that are dying in prison, or the numbers, the spike is higher in prison. How can we decongest and make sure things work? So once again, we never shy away from our challenges. That is a challenge that you're pointing out to us. And we are saying we're looking and analyzing that data to be able to see how best we can maneuver within the resource that is available. This is one area we would love additional resources to, but we really need to also continuously be realistic about it while we're protecting our citizens.
All right, let's look to the future now. Vaccines are out there, manufacturers are busy. What's Zimbabwe's vaccine rollout plan? When do you start getting them? Is the rollout plan there? What are you looking at?
This is everybody's favorite topic question. Vaccines in Zimbabwe, when are we rolling it out, and so on. I'm happy to announce to you that we have not been sitting idle. We have been working flat out. We have been guided by the WHO, Gavi, COVAX facility templates, where we use to do assessments in October, in November, as part of our preparedness to say, let's check our systems. Where are we? And we saw lots of gaps. We started running around, plugging them, addressing them, you name it. We did another one in November, and we're still having a few gaps here and there. And we're now working on those to put everything in place. So we are very much on target in terms of preparing in a scientific way, if you like, so that when indeed we're ready, we then roll out. So to answer your question, when do we do that? We're quite clearly guided guided by those assessments, what the challenges are, how far we have addressed those gaps in order for us to move forward. For example, if we find ourselves in those assessments that, whoa, our cold chain is so poor that it will take us maybe 20 years to sort it out, and yet we want a vaccine now, we are probably not going to then go for those vaccines that require such really interesting temperatures, because we won't be able to manage, but we will still introduce a vaccine. So the timelines that you're asking about are very clear in our minds, because they will be guided by those things that are coming out of those assessments, and in terms of how we are addressing the challenges that we identify in those assessments. So we're very, very clear. And yes, to answer the part 2 of your question, do we have a rollout plan? Absolutely. We already have a draft, but as long as we have these gaps and we're assessing and putting in place things and so on, it is very prudent for us to make sure that we're not issuing out something which still has gaps here and there, because we do not want to create panic. I do know most have said, oh, we've seen South Africa's plan, we've seen so-and-so's plan. Zimbabwe is not South Africa, it is not Kenya. We do have a draft plan, but we are saying we also need to manage how we issue it out to make sure we're not creating panic. We want to make sure our population is served appropriately, very well, in a scientific way. So we are on track. We will certainly issue those out, and we'll certainly be talking to you as well.
So when is the first dose going to be given? Do you have a date at least that you're planning to start? When's day one?
Well, again, I think you are taking me back to what I have perhaps just said, to say I cannot give you a day one, because that might create confusion as we are finalizing our plan to issue out to our population, so that we are dialoguing, we are advocating, we are speaking from the same page, including even that day one. I know in media recently, people were saying, oh, we heard the Permanent Secretary Minister of Health saying they'll prioritize certain people. What about us? You can already see the anxiety from our population. Some people are not going to get it. And yesterday I had to really explain that no. We're not saying there are certain populations that will be chucked out. We're simply saying if you have 20 doses that have arrived today, when you're going to receive 100, for example, you must prioritize those at the highest risk. Our healthcare workers who are working in ICU, who are sectioning those severe cases, severely ill cases and so on, so that they continue the excellent job that they are doing. And then of everybody else will also eventually get their doses. But you really have to prioritize.
Okay, so no fixed date. Do you have an idea of the type of vaccines that you're looking at? China is a great friend of Zimbabwe. Sinopharm is one manufacturer there. Will Zimbabwe be seeing COVID-19 vaccines from China as well as Europe?
I think it's we have put everything on the table. Basically, as I said, we are trying to be very scientific about how we introduce vaccines. We're guided by the science coming from the ground in terms of those assessments that I talked about, and hence they will tell us. Should we be getting the China vaccine, or should we be getting the UK vaccine, based on what our system can handle? I think it is so critical for everybody, our population, to appreciate that. This is the health of our nation. It has nothing to do with the friendships and so on and so on. I mean, of course, we do want our friends to help here and there, but we really want to stay focused in terms of the science. What is best for Zimbabwe? What is it that we can manage? If this is the vaccine that will address all those issues that came through the assessments, our preparedness, that's the one we'll go for. We have put all of them on the table. As I said, we continue to really be guided by the very excellent frameworks that the COVAX facility has put out there. But at the end of the day, it is the government of Zimbabwe that will put the final decision on which vaccine we will have. And that, of course, will be communicated, because there's no way a vaccine will simply be rolled out without people knowing what type of vaccine it is. And so really managing the process, ensuring that our population is comfortable, avoiding all the infodemics that we're seeing about vaccines, avoiding the panic that might come with half-baked information, is so critical for us as we move forward with our preparations.